So today we will be discussing about the anterior and the medial aspect of the elbow joint. When we talk about the anterior aspect of the elbow, okay, this is a published technique of mine. That is, I go with the 3-2-1-1 rule, where 3-2-1-1 is an easy way to remember what are the structures which are there on the anterior aspect. So here, if you see it, 3 goes for the 3 muscles, right? So if you scan from the lateral to the medial side, you are going to have the brachioradialis, okay, then you are going to have the brachialis, and then you are going to have the pronator teres. Fine. So 3 is for the 3 muscles. Now when you go to the 2 is for 2 nerves, which I'm planning to now modify in my upcoming book. I'm going to make it again 3, okay, and you will see what exactly is that third one. So 2 here is for the 2 nerves. So you have the radial nerve on the lateral side, right? And then you have the median nerve on the medial side. So you have this radial nerve, and this radial nerve is going to be between your brachialis and your brachioradialis, right? And then you have your median nerve, and this median nerve is going to be between the brachialis muscle and your pronator teres. Fine. Then 1 is for your 1 tendon. Which tendon? That is the distal biceps tendon we are talking about. And then we have 1 artery. Okay, so that is the brachial artery. Fine. So 3 is for the 3 muscle, 2 is for the 2 nerves, and 1 is for the tendon, and 1 is for the artery. So this is an axial section. If you will just understand this, when you look at the sonoanatomy, it becomes super easy for you to see what exactly we are looking for, right? So whenever we scan the anterior elbow, right, we usually look for an undulating line, because this undulating line will be corresponding to the distal articulating end of the humerus, right? So here you have this rounded one, which is going to be your capitulum, okay? And then you have this V-shaped, that is the trochlea. This white color thing which you are able to see, that is the hyaline cartilage, okay? Then you have the joint space, and on the top you're going to have the capsule, okay? Now again you follow the 3-2-1-1 rule. So 3 is for the 3 muscles. So you have the brachioradialis here, then you have the brachialis here, and then you have the pronator teres. 2 was for the 2 nerves. So here you have the radial nerve, and on this side you are going to have the median nerve. 1 was for the tendon. So this is the tendon, where this is your short head, which is on the medial side, and then you have the long head, which is on the lateral side. So remember it like L is for L, right? So long is for lateral, then of course your short head is going to be the medial one. And then you have the brachial artery along with the vein, okay? So this is how basically we look for the anterior elbow structures. So now let's watch a video here, and where I'm just explaining you how exactly we are supposed to scan. So to scan the anterior aspect of the elbow joint, so this is the table. My volunteer is sitting across the table. Shoulder is into 90 degree of forward flexion. Elbow is extended. Forearm is supinated and palm facing up. So my probe is in short axis with the aspect marker towards the lateral side, and I have just kept it over the elbow crease, where I should be seeing the rounded capitulum and the V-shaped trochlea. So either you can start from here itself, where you are able to see this undulating line, or you can start from above and just come to this point where you are able to visualize this distal articulating end of the humerus. Alternatively, you can start from below. Again, you can come back to this distal articulating end of the humerus. So it is up to you which one you want to follow. Either you can keep the probe exactly over the elbow crease and look for this undulating line, which is formed by the rounded capitulum and the V-shaped trochlea, or you can just start from above or below. So now let us just see all the structures which are here. So this one is the capitulum, this one is the trochlea. This homogeneously hypoechoic structure which you are able to see here, that is the hyaline cartilage. So this muscle which you are seeing here, that is the brachialis with the tendon inside. This one is the brachioradialis, and what you will be seeing here when I'll be showing you by sliding my probe medially will be the pronator teres. This is the distal biceps tendon.
brachial artery, and here you are going to have the radial nerve, and this one is your median nerve. So now apply the 3, 2, 1, 1 rule. 3 stands for the 3 muscles. So we have brachioradialis, then brachialis, and then the pronator teres. 2 is for the 2 nerve, that is the radial nerve and the median nerve. 1 is for the tendon, that is the distal biceps tendon. Another one is for the artery, that is the brachial artery. So let's see the structures once again. So we have our brachioradialis, radial nerve. This is the brachialis, distal biceps tendon, brachial artery, pronator teres, and the median nerve. And this view where our probe is in short axis to the distal articulating end of the humerus with the aspect marker towards the lateral side is referred as home page view for the anterior elbow joint.
So then we'll be moving towards how exactly we will be identifying each structure. Okay, this was just a brief of what all are there on the anterior elbow, right? And now we will be just going specifically each structures, I should say, okay, one by one. First, we will start with how exactly are we supposed to identify the anterior joint recess, okay? So do remember that whenever we are looking at the recess, so recess, you remember it like, as if there is a sandwich which you are supposed to see, right? So when you are looking at the distal end of the humerus, we have a radial fossa and we have a coronoid fossa, right? Coronoid fossa, it's sitting on the top of the trochlea, and your radial fossa is sitting on the top of the capitulum, right? So where whenever we are flexing, coronoid process of the ulna and the radial head, they will be just getting inside. They'll be just stucking there, right, in those fossas. So fossas, basically, they are just like a spoon-shaped structure. Remember it like that. So we have the shaft. Okay, so we are looking at the coronoid fossa now. So this is the shaft of the humerus, right? And then you are going to have a depression, right, like this. So how it becomes, it is just like a spoon. Fine, you have the shaft and then you have the fossa, and we are looking at the sagittal section, okay, not the axial section. So you have the shaft, you have the coronoid fossa, right, and then you have this one which is your trochlea, right, and then your, I should say, the coronoid process of the ulna. Now on the top you're going to have the synovial membrane, and on the top you're going to have the fibrous capsule. Now in between this synovial membrane, that is one part of the sandwich, you are going to have your fat pads, okay, and then this will be the capsule. So if I have to ask you that what exactly, how exactly the fat pads they are, what exactly is their location? So it is extra synovial, but it is intracapsular because it is located outside the synovial membrane, but it is within the capsule, right? So in this picture, this green is just telling you about the synovial membrane, and this white structure is the capsule, okay? So that was about the anterior-medial joint recess. Now, once you are going toward the radiocapitular joint, right, you will be seeing that recess. So here, this green color is the capsule. This white color is the synovial membrane. And here also you have a spoon. So this is the shaft. This shaft has got a concave shaped depression, which we are going to call it as radial fossa now, right? Because it is over the radial head, where this head has to go and get itself lodged. And then you are going to have the capitulum, okay, and that is your recess, fine, and this is your radial head. Now in between these two, you are going to have your fat pads. Very important, because these fat pads, they will always be lying in close approximation with the bone, and if they are going to lift it up from their place, so that is an indirect sign of just looking at an effusion, right? There might be an effusion which is just pushing it up, right? So that is the importance of learning this fossas and what exactly is present within that fossa. So let's see the demonstration.
So this is our home page view. So I'm going to slide my probe medially and I'm going to keep the trochlea at the center of the screen. Now I'll be rotating my probe to 90 degrees. And at the same time, I need to increase the depth also. So once I have increased the depth, I will be able to see something like this. So this concave shaped depression is the coronoid fossa, which is harboring the fat pads. This is the trochlea, which is having the hyaline cartilage over it. Then we have the pointed coronoid process, and what you are seeing here is the capsule of the elbow joint. This is the brachialis muscle in the longitudinal axis, and this one is your humero-ulnar joint. So we were here, okay. So now I'm going to keep the same orientation. That is, I'm looking at the longitudinal axis of the brachialis muscle, and now I'm going to slide my probe towards the lateral side. Maintaining the same orientation, I'm just sliding my probe. And once I'm sliding my probe, I will be able to see something like this. So now this concave shaped depression is the radial fossa, which is harboring the fat pads. This is capitulum with the hyaline cartilage over it. This square shaped structure is the radial head, and what you are seeing here is the synovial flinch, and this is the capsule of the elbow joint, and what you are seeing here is the radiocapitular joint.
So that was about the anterior joint recess. Now coming to the distal biceps tendon. So when you are seeing the distal biceps tendon at the elbow, this is one of the most important structure which you should know how to scan, right? Because the most commonest cause for the anterior elbow pain is pathologies related to the distal biceps tendon. And it is one of the toughest structure it seems to see under ultrasound, right? Okay, that's why we have various approaches to look for it. Fine. So distal biceps tendon, when you are looking, we have already seen that it has got a short head and it has got a long head. So short head is towards the medial side and the long head is towards the lateral side. So this distal end will be sending a, fibrous projection towards the medial side, right, which will be getting intermingled with the flexor pronator complex, and we call this as the Lesatus fibrosus or the distal biceps tendon aponeurosis. Fine. So how to look for it? Because this is also a very important structure. Whenever you are looking at the pathologies which are related to your distal biceps tendon, either a partial tear, right, or a complete tear, then you need to look for one very important thing, that whether there is a breakdown of this Lesatus fibrosis or not, right? So this is equally important for this reason. Second reason is if you can have a thickening of this Lesatus fibrosis, right, and that will be one of the causative factor for causing the medial nerve entrapment and the entrapment of the brachial artery, because both of them, they will be passing just beneath it. Okay, so just have a look at the Lesatus fibrosis in the next slide. Before that, just remember one thing about the distal biceps tendon is we have seen that the short head is towards the medial side and the long head is towards the lateral side. So what happens once this tendon, from the myotendinous junction, this tendon is going towards its insertion. So you have an approximately 90-degree rotation, okay, of these two heads, which you can see in the picture. And that's the reason your long head will be going up and your short head will be going distal, okay. So just see the distal biceps tendon in short axis and the Lesatus fibrosis scanning.
So now my probe is at the home page view. Fine. From there, I am going to go a little more up, and once I am going up, I will be able to visualize the short head, which is medial, and the long head, which is lateral. Now to visualize the Lesatus fibrosis, I need to bring my probe down from there, and I'm going to slide my probe medially. Once I have slided my probe medially, I will tilt the medial side of the probe towards the table. So now I have just reduced the depth so that we can see the structure nicely. So now this is your distal biceps tendon, and this brillar structure which you are seeing going above the brachial artery and the median nerve is the Lesatus fibrosis or the bicipital aponeurosis.
So now bicep scanning, we have different approaches. You can just scan it through the anterior approach, but that is the toughest one because as you have seen, it has got an oblique insertion, right? So you are gonna have lots of anisotropy when you will be examining it through the anterior approach. That's the reason we have various approaches to look for the distal biceps tendon. One such approach is the lateral approach, where we will be looking for the distal biceps tendon, where we will be making use of the muscles which are present on the lateral aspect, and that window we will be utilizing to look for the distal biceps tendon. Now, there are certain, I should say, the shortcomings of this approach. One very important is whenever we are looking at the distal biceps tendon from the lateral side, we usually utilize that supinator muscle window, right? So this supinator muscle will be usually casting a refractile kind of a shadowing. So this will not be allowing us to visualize the distal biceps tendon very nicely. Second thing, you have the radius, right? So this radius will also be a casting and acoustic shadow, and we will not be able to see the insertion of the distal biceps tendon on the radial tuberosity very well, okay? Then we have the medial approach, where we are using pronator muscle and the brachial artery as the window through which we will be peeping inside the distal biceps tendon. As it was given by Smith et al., they were the one who just came up with this approach in 2010. And they have just said that, with this approach, you will be able to see nicely the insertion of the distal biceps tendon on the radial tuberosity. And there is not going to be any kind of, beam attenuation, because we are going to have the artery above us. So this artery will be causing the posterior acoustic enhancement, right? So this will be allowing us to look at the biceps tendon very nicely. And we do not have this supinator over there, which will be cast the refractile shadowing. So we will be able to see the distal biceps tendon very nicely with this approach. Then we have another one, that is the approach we basically use when we have to go for an intervention of the biceps tendon. That is the only one approach which is recommended if you really want to put a needle inside the distal biceps tendon, either in case of a partial tear or in case of a tendinosis, right? And this we say as the posterior approach or the cobra position. Your shoulder will be into the forward flexion. You will be flexing the elbow joint to 90 degree and then hyperpronating and then flexing your wrist. And we will be looking for the biceps tendon from the posterior side. Now, this is my published technique, which I invented. Okay, so I will be sharing this technique of mine. If you will utilize this technique, believe me, it is one of the easiest technique to look for the distal biceps tendon. Not because it is the it's my own technique. It is because I could see that when I used to scan the distal biceps tendon, I used to find it so difficult, many a times to scan it from the anterior aspect. Okay, and I used to think, oh my god, so many approaches then I have to look for just to evaluate the distal biceps tendon. And that was the reason I just came up with this technique of mine. Okay, so you just listen to this video. It has got all the techniques to identify the distal biceps tendon.
My probe is with the home page view. I am going to slide my probe medially until I am able to visualize the pronator teres in the short axis, which is this structure. Now I am going to rotate my probe and I will be looking for the pronator teres in the long axis. So this is pronator teres in the long axis. Then I am going to tilt my probe until I am able to visualize the radiocapitular joint, which is this one. Now I am going to slide my probe, maintaining the same orientation until this radial head will come here. So I'm sliding my probe. Now it has reached to the other end of the screen. Fine. And I could see even the pulsation of the artery very nicely here. Now I'm going to ask him to flex his elbow. So the moment he has flexed, I am able to visualize the distal biceps tendon very nicely.
So here I would like to tell you one thing, that the flexion, how much to flex, right? It is just few degrees, I should say. You can just see in the video itself, you might be seeing that it is still extended. Okay, so it's just a 5 to 10 degrees, you have to just go for the flexion. The moment you are going to do that, you will be able to see the distal biceps tendon very nicely.
So I have kept my probe over the radius in the short axis. I will try to move up and down, and I will just look for the supinator muscle, which is this one, the superficial and the deep head, and this is the radius in the short axis. Once I have identified that, I am going to slide my probe anterior. Once I have slided my probe anteriorly, I will be able to see the distal biceps tendon as a fibrillar structure. So this is olecranon process. 2 fingers up. I am going to keep my probe in short axis with the aspect marker towards the lateral side. So this is ulna in the short axis. Now I am going to slide my probe laterally, and once I am going to slide my probe laterally, I'll be able to visualize the distal biceps tendon like a bird beak appearance on the radial tuberosity. And now I'll be asking him to go for the supination and the pronation of the forearm, and we will be able to appreciate the gliding movement of. So you can see the supination and the pronation movement, and here we are able to appreciate the smooth gliding movement of the distal biceps tendon. So in order to identify the distal biceps tendon with the medial approach, we'll keep our probe in such a manner as if the caudal end of our probe will be resting over the medial epicondyle. So this is medial epicondyle. And then we are going to slide our probe maintaining the same orientation until we are able to visualize the radial head, which is having the articular cartilage over it. Once we are able to see that, we are going to slide our probe little more distally until we are able to visualize the artery. So this is the artery which has started coming up. Now at this point, we will just rotate cranial end of our probe at approximately at 1 o'clock position, and we will slide our probe down, and we'll be tilting the footprint of our probe towards the lateral side. So once we are doing that, we will be able to identify the radius, and this is the distal biceps tendon. This is the artery. I have modified the medial approach a bit, and if you'll follow this, it will be much more easy for you to identify it. And then we can go for the supination and the pronation. Just to confirm, we are looking at the distal biceps tendon only.
So that was about the various approaches of the distal biceps tendon. Then coming to the median nerve. So median nerve, 3 sites of entrapment are there. That's the reason you need to just look for it very nicely. The most commonest is the pronator teres as compared to the other one. So median nerve at the elbow first is lied beneath the latissimus fibrosus, which we have already seen. Okay, and then it passes between the 2 heads of the pronator teres. Okay. So these the pronator teres, 2 heads, and then it will be just passing beneath the 2 heads of the flexor digitorum superficialis. And the tip to identify the deep head is you will always be having this ulnar artery, which will be just lying beneath the deep head of the pronator teres. So watch this video.
I will keep my probe in short axis with the home page view, and I will be sliding my probe towards the medial side. Once I am doing that, I will be able to visualize the median nerve in the short axis lying adjacent to the brachial artery in a facial plane in between the brachialis and the pronator teres muscle. So once I have identified it in the short axis, I usually follow it in the longitudinal axis because that's much more easier for us to identify it between the 2 heads of the pronator teres, that is the humeral and the ulnar head. So now I have rotated my probe to 90 degrees, and we are looking at the longitudinal axis of the median nerve between the pronator teres and the brachialis muscle. So maintaining the same orientation, I am gonna slide this probe down, and once I'm sliding the probe down, I will be able to see the median nerve between the 2 heads of the pronator teres and the ulnar artery, which will be lying at the deeper aspect of the ulnar head. So I'm sliding my probe towards the wrist, maintaining the same orientation, that is the craniocaudal orientation, where we are looking at the longitudinal axis of the median nerve. So I'm sliding my probe down, and if I'm not able to see it, I'll just toggle my probe. I'm sliding down. So if we will slide our probe distally, we will reach here. So this is the humeral head of pronator teres. This is the ulnar head of pronator teres. So we were here where we have looked for the median nerve in the longitudinal axis passing between the two heads of the pronator teres with the ulnar artery now lying just on the deeper aspect of the ulnar head. So you can see the pulsation of this artery very well. So once I have rotated my probe, you are able to appreciate the same thing. So this is the artery, this is the median nerve which is lying between the two heads of the pronator teres. And then if we are going to slide it more distally, you will be seeing that this median nerve will be then entering the arcade of your flexor digitorum superficialis. So I'm sliding it down. So here is your median nerve and then it lies in a facial plane between the flexor digitorum superficialis and the flexor digitorum profundus. I will keep my...
So that was about the median nerve. Then coming to the brachialis. So brachialis has got two heads, superficial head and the deep head. And the deep head, it inserts on the coronoid process as well as some portion of the ulnar tuberosity. And the superficial head, it inserts on the ulnar tuberosity. So let's see the scanning.
So now my probe is in the home page view where I am looking at the brachialis in the short axis. So now I'll be rotating my probe to 90 degrees and right now I am looking for the brachialis in the longitudinal axis. And then I'm going to slide my probe distally. So now I have reached to the insertional site. So this is the deep head and this is the superficial head of the brachialis. And this hole is the insertional site for the brachialis muscle.
So when you talk about the brachialis insertion, so do remember it can have a tendinous insertion, it can have a muscular insertion, or you can have a mixed insertion as well. Then coming to the medial collateral ligament. So medial collateral ligament has got three bands. That is the anterior band, okay. Then you have the posterior band and an oblique or the transverse band which will be connecting these two. Now, the most important band which is responsible for maintaining the stability on the medial side is the anterior band, which extends from this medial epicondyle and it goes up to the sublime tubercle of the ulna. Posterior is from the posterior aspect of this medial epicondyle and it is on the medial side of this olecranon process, right? Transverse you will not be able to see under ultrasound. But posterior, yes, you will be able to see some portion of it when you are looking at the cubital tunnel. And this anterior band of the ulnar collateral ligament, you will be able to see when you are looking at the common flexor tendon. Okay, so let's see the scanning of the ulnar collateral ligament first.
So this is the medial epicondyle and I have kept my probe with the cranial end resting over the medial epicondyle and the caudal end exactly in line with the ulnar border of the forearm. Once I am doing that, I am able to appreciate something like this. So our probe was here, cranial end over the medial epicondyle and the caudal end exactly in line with the ulnar border of the forearm. So this is the cranial side and this one is the caudal side. This is the medial epicondyle and this one is the trochlea. This is the ulna. This is the trochleo-ulnar joint. So what you are seeing here, this structure, so this is the anterior band of the ulnar collateral ligament.
Then coming to the common flexor tendon. So common flexor tendon, we have a tendinous portion, okay, from which all the muscles, they will be taking its origin. And this tendinous portion is located on the medial epicondyle, right? So here you have the pronator teres, okay. Then you have the FCR. Then you are going to have the palmaris longus. Then you are going to have the FCU. And beneath that, you are going to have your flexor digitorum superficialis. Okay. So one head of the flexor digitorum superficialis will be from this humero-ulnar side and the other one is from the radial side. That's why we say it has got two heads. So let's see the scanning.
So once we have identified the anterior band of the ulnar collateral ligament, we will be keeping the cranial end of our probe fixed, and we will be rotating the caudal end of our probe towards the thenar eminence. So once we have done that, we will be able to appreciate the common flexor tendon nicely. So this is medial epicondyle, trochlea, ulna, trochleo-ulnar joint, and what you are seeing here is the common flexor tendon. This is the anterior band of the ulnar collateral ligament.
So just do remember that whenever you are looking at the UCL, these probe positions are very important, right? Because if your probe is exactly, if you're looking at the common flexor tendon, do not expect that you will be able to make out any pathologies which are related to UCL, right? Because that is not the correct position to visualize the UCL. But when you are looking at the UCL, okay, this position is totally different. So you should not be thinking of any pathologies related to your common flexor tendon, right? So do follow these probe positions whenever you are scanning the UCL and the common flexor tendon. Then coming to the cubital tunnel. So cubital tunnel, you have the medial epicondyle on one side, and then you have the olecranon process on the other side, right? And this posterior band of the ulnar collateral ligament, along with the capsule of the elbow joint, will be forming the floor. And then you have the Osborn's ligament, which will be forming the roof, right? So ulnar nerve is going to pass through this osteofibrous tunnel, and later on it passes between the two heads of the FCU, okay? And these two heads of the FCU, they will be just having an aponeurosis. So some people, they just call it as an arcuate ligament, and some people, they say that it is just a continuation of the Osborn's ligament. Then this ulnar nerve will be passing between the FCU and the flexor digitorum profundus. So let's see the scanning.
So I have kept my probe bridging the medial epicondyle and the olecranon process, and my aspect marker is over the medial epicondyle, and we are able to appreciate something like this. So our probe was like this. This is the medial epicondyle and this is the olecranon process. This was the aspect marker side. So this is the aspect marker side. So this is medial epicondyle. This is olecranon process, and this is the ulnar nerve. This is the Osborn's ligament, and this is the posterior band of the ulnar collateral ligament. So from here, we are going to slide our probe distally. Once we are going to slide our probe distally, we will be able to see something like this. So our probe was here, and we have slided our probe distally, that is towards the wrist. And once we have done that, we are able to appreciate the ulnar nerve. So this is the ulnar nerve, and this is the ulnar head of FCU, and this is the humeral head of FCU. And on the top, that is the aponeurosis, which is connecting these two heads. And if I'm going to slide it little more distally, you will be able to see the two heads merging and forming the muscle belly of the flexor carpi ulnaris. So this was our first position. From there, we have slided down and we could see the two heads of the FCU. And if I'm going to slide little more, you will be able to appreciate this is FCU, this one is the digitorum, and this is the superficialis. So once I have identified the ulnar nerve in the short axis, I have rotated my probe, and now I am just looking for it in the longitudinal axis. So this is the ulnar nerve in the longitudinal axis. Aspect marker is now here, so it is cranial and this is caudal. So now we will be going for the dynamic evaluation of the ulnar nerve, and during this maneuver it should remain in close approximation with the medial epicondyle, like how it is right now. It should never come anterior to the medial epicondyle. So now I am asking my volunteer to move his elbow into flexion, and you can see this is the ulnar nerve, this is the medial epicondyle. And it has always remained posterior to it during the dynamic maneuver.
So those scanning is not, the pathologies are not a part of this webinar. But still just see how exactly what I'm trying to tell you, what exactly is the normal. So normal we have approximately we have seen. So this usually we say subluxation when it is just coming out of the cubital tunnel, when you are just flexing your elbow and just going back when you are extending your elbow, right? This is dislocation, fully anterior to it, okay? It has fully come out. So this is dislocated median nerve. And I'll be now showing you a video. Recently, I have seen this. Okay, so yes, that is triceps snapping syndrome. So that was just a brief about the scanning of the anterior and the medial elbow structures.